if we're dealing with the issue being in the tendon or at the tenomuscular junction, what we want to do is we want to pronate the forearm and then flex the wrist. Okay, that puts the tendon on tension, and that allows us to hold it in place better, right? If we leave it off tension, the thing is just going to roll around like crazy. If we put this back on tension here, then it's going to stay in place for us much better. Okay, if we need to get to the epicondylar ridge, okay, so we go off the epicondyle here, we need to come anterior to that. We want to actually put them in supination, wrist in neutral, and now I can get into that epicondylar ridge much easier because there's enough slack on that tissue for me to get in there. Now this is going to be more of a tenoperiosteal junction issue, right? And they should be tender, right? It should be painful when we get this. So technique-wise, how do we do this? This is my preferred technique, right? I will put my fingers just like this, using my index finger as my contact point. So here for the tenoperiosteal or tenomuscular junction, or the body of the tendon, again, I'm reinforcing my index finger with my middle finger, and my friction is across fibers. That's why we call it cross friction massage, right? And I'm trying to produce this with my shoulder or even with my trunk. So I'm not sitting here using my finger, curling it back and forth, right? If I go to the epicondylar ridge, put her back into this position. Again, same thing, I'm taking that index finger and I'm bringing it in there. And this is a sawing motion. Again, creating that motion with my shoulder so that I can produce this for a good 3 to 5 minutes, I would say at least. And now what we should get with cross friction massage is after somewhere between 90 seconds and 2 minutes, the tissue should go numb. Okay, so you can let them know, like, this is not going to be the best part of your day here for the next minute or two, but after that it should feel much better. You should know about when this is occurring because your fingertips should start going numb too. Okay. Some pitfalls here with this is if the tissue goes numb within the first minute, it means the tissue is normal. You just spent a minute cross-frictioning something that doesn't need it. If it gets worse after the first 2 minutes, it's not a simple tendinosis, it's probably facilitated, right? And this is, I think I told this story before. I had a patient who came in with bilateral lateral epicondylitis, or a diagnosis of bilateral lateral epicondylitis. He'd seen a bunch of doctors, PTs, chiropractors, all this sort of stuff, and he'd even had surgery on one of the arms to release it. It was still there, still bothering him. And so my first suggestion was, well, it's probably not a true lateral epicondylitis. It's probably a facilitated referral coming from the lower cervical spine. He didn't believe me, essentially, is what it kind of amounts to off the bat. And I was like, well, I can prove it to you if you want. I said, well, how can you do that? And I could have gone the route of saying, well, let's fix this and we'll show you all the weakness and all that sort of stuff, but it's such a process. I was like, if I do the typical treatment for this, which would be a cross friction massage, and I'm correct, it'll make it worse. I'm like, but if it desensitizes, it'll make you feel better, and you can walk out of here saying, I told you so. So we did that. He came back 2 days later. It's just like, man, that was a miserable 2 days. Like, that was so much worse after the fact. So he agreed with me. We treated actually ended up being the upper thoracic spine we had to treat, taking some pressure off the lower cervical spine, and he did great. 3 visits later, he was back to normal. So that's the kind of reaction you can get from frictioning something that's facilitated. Okay, but they present very similarly, right? You'll see this in clinic a fair amount, where it's going to be painful with grip, it's going to be painful with resisted wrist extension. Essentially, the tissue is just all wound up, right? You can get this kind of what we consider a pseudo-tendonitis going on right there. But eventually that structure is going to start to break down. Right? Constant tension will eventually do that to you. Okay, so that is step one. We'll do our frictions to that tissue, heat that tissue up, and then we're going to do our manipulation. I have you sit up here for me. Now there's a couple of must-dos here before we perform this manipulation. We have to ensure that the patient has full wrist flexion. Okay, that there's not an articular loss of wrist flexion at the wrist. Okay, so we can test that here. Very simple to do. We also have to ensure that the patient has full elbow extension. Okay. Once we know those two things, we've done our friction, we can set this technique up. What we're going to try and do here, I'm going to try and get as far behind the patient as I can. We're going to flex the wrist, pronate the forearm, and extend the elbow, right? And right there, what we should run into in a patient that this technique is appropriate for is we should run into the soft tissue tension where that adhesion is, those adhesions are, right? So we're not taking this patient into a position where we're just going to bang against the joint, because we're going to run into that soft tissue barrier before we get to that. Okay? So we're going to take her into this position, and we're not going to really manipulate her, because all I'll end up doing is banging her olecranon together. But the idea here is to keep the wrist flexed, elbow pronated, and then we're going to thrust down into extension here, rupturing through that scar tissue. So it's a very abrupt push down, right? Just like that, down through the elbow. I've done this a couple of times in clinic. It's not something I've done a ton of, but I've done it a few times. I'll tell you, there can definitely be a kind of gross sounding noise that's associated with this. It's definitely this. It sounds a little bit like paper tearing. It's kind of muted, I suppose, but that's kind of the impression that you get. But if you're doing it right, that's what you should get. Okay, and then after that, we need to work on. Typically, going to need some anti-inflammatory stuff here, right? So you're going to have mice it for a couple of days. You could do some ultrasound or some stim, something like an interferential current, something like that, because you did break through some fibers there, so that there could be some inflammation as a result. And we're probably going to have to find whatever it is that set this thing off in the first place. All right, so that could be a problem at the wrist, it could be a problem at the elbow. Doesn't really matter where it is, we got to fix that, otherwise it's just going to come back eventually.
Would you have do some repeated motion in the first few days after?
Sure, yeah, I mean, essentially you want to be able to maintain the extensibility of that, right? So whether that involves just stretching in this position, or if you want to take them all the way into this position here. The position here I always have a bit of a tough time with, because that's also a radial nerve tension position. So essentially, before you go through and do the actual manipulation, you want to do a bit of a pre-manipulative pull to make sure there's no parasitic things that occur. If there are, you either need to clear out things here through the shoulder girdle and into the upper thoracic, or you can have them tilt the head this way to slacken off the nerve tissue. It's a possibility as well. Okay, any questions there?
Can I see where your mobilizing hand placement is again?
The thrusting hand?
Yeah.
Yeah, so it's going to be right on the back of the elbow.
Okay.
Just like this.